Good morning, everyone. So our today topic of discussion would be endometrial carcinoma reporting and updates. Myself, Dr. Khadeeja. So I'll be dividing this topic mainly into three parts. I'll just give you a brief idea about what we already have an idea, and then we'll go to updates and ultimately to the reporting. So generally, endometrial carcinoma presents in postmenopausal women. More than 90% of the women are more than 50 years of age, and median age group that endometrial carcinoma was seen was about 63 years. Patients have presented with abnormal postmenopausal bleeding, and symptoms were similar, just like in ovarian carcinoma. The women mostly had prolonged exposure to unopposed estrogen by estrogen hormone therapy or nulligravida. So these patients generally have estrogen, there's unopposed estrogen in these patients, so patient presented with endometrial carcinoma. So this is a WHO and ISGYP, that is International Society of Gynecologists and Pathologists classification of 2019, where they divided the endometrial carcinomas on the basis of morphology. So it is as follows. It's endometrial carcinoma with squamous differentiation, Villoglandular and secretory differentiation. Mucinous carcinoma, now at present WHO, mucinous carcinoma has been removed, but just for the morphology and to have an idea about the morphology, we have kept this classification. Then there is serous carcinoma, clear cell carcinoma, neuroendocrine carcinomas, undifferentiated and dedifferentiated carcinomas, and mixed cell adenocarcinomas, and malignant mixed Mullerian tumors. So we'll be looking at them one by one. But in the first place, as we know that endometrial carcinoma is the most common invasive cancer of the female genital tract. So it was broadly divided by the Bachmann in 1983 into type 1 and type 2. So type 1 tumors, the patients were about 55 to 60, mean age range was about 55 to 65 years. The patient had unopposed estrogen with obesity or diabetes, hypertension, comorbidities. And the morphology that was seen in type 1 was mostly of endometrioid, which means it resembled the proliferative phase of the endometrial glands. The precursor lesion was hyperplasia, and the genes that were mutated mostly were seen as P10, POL, and TP53. Though this tumor was indolent and spread via lymphatics, but when we compare it to the type 2 tumors were seen in 65 to 75 years of age, and the clinical setting. The clinical scenario was generally the endometrium was atrophic and the patient was thin. Now, morphology that was seen in type 2 type of carcinomas was serous type, clear cell type, and mixed Mullerian type. The precursor lesion that was seen in type 2 was serous endometrial intraepithelial carcinoma, and the mutated genes that were observed most commonly were TP53 with PIK3CA and CCNEI. But when we look at the behavior of type 2 tumors were generally aggressive, and they spread via lymphatics and intraperitoneally. Now, there are a few syndromes that are associated with endometrial carcinoma that we should have an idea about. The most common that I would comment on would be Lynch syndrome, which is also known as hereditary non-polyposis colorectal carcinoma syndrome. It is an autosomal dominant condition, and the tumors that mainly are in this syndrome are endometrium, stomach, breast, and ovary. The main molecular problem with it is the DNA mismatch repair. Now, there's one more syndrome called the Cowden syndrome, which is also the multiple hematoma syndrome. There's this P10 gene mutation, which is tumor suppressor gene, and the carcinomas that was seen in Cowden syndrome was endometrial carcinoma, breast, and follicular thyroid carcinoma. Now, when we report a case of endometrial carcinoma, we should really have an idea about the grading of the endometrial carcinoma. So there are two gradings which we comment when we give a report of endometrial carcinoma. First is a FIGO grading, which is dependent on the architectural pattern of the tumor, and then there is nuclear grading. So in a FIGO classification, or FIGO grading is divided into three grades. The first FIGO grading is about when we look at the tumor, and mostly it's the glandular proliferation. But when there is 5% or less of non-glandular, non-squamous solid growth pattern, so we give it as FIGO grade 1. Again, if this pattern is 6% to 50%, then we give it as grade 2. And then when it's more than 50%, we give it as grade 3. Now, when it comes to nuclear grading, there are three nuclear gradings that we have seen. Grade 1 would be the nuclei is oval with mildly enlarged and evenly dispersed chromatin, compared to grade 3, which is markedly enlarged and pleomorphic with prominent nucleoli. So grade 2 is between these both gradings. So when I'll be saying grade on histology or the architectural pattern, I'll be referring to FIGO grading and nuclear grade henceforth. So we also should have an idea about patterns of myoinvasion. The few patterns which are very important are, for example, diffuse infiltrating invasion, when the tumor is invading into the myometrium, also giving a stromal response along with the invaded glands with the loose stroma around it. Now there's also called broad invasive front, where the front or the tumor is like pushing, but it's very difficult to differentiate it. You have to compare it with the non-invasive part of the endomyojunction. The most important that I would like to comment on is a microcystic, elongated, fragmented type of invasion, where this type of pattern, the neoplastic glands generally leave the endomyojunction and are dispersed inside the myometrium, has flattened lining and looks like microcysts. So this is a very type of invasion I'll be commenting upon it later. Now, just in brief, the histological patterns that we know about the endometrial carcinomas. I've just kept this slide for the proliferative type of endometrium. When we say endometrioid type, we are saying endometrial proliferative gland type. So when we comment on endometrium, we'll be commenting upon the glands, upon the stroma, upon the lining epithelium, and upon the individual cells. So now this is endometrioid type grade 1. Again, just to remind you, grade 1 is a FIGO grade 1. So in this, what do you see? You see a lot of hyperplasia of the glands, and barely you see stroma over here, and it resembles the proliferative type of endometrium, with nuclei is in grade 1, nuclei is only mildly enlarged. But now when we compare this slide you can see we have glandular pattern, that is grade 1, because the solid pattern is less than 5%. So we can see glands, but when we do see at the nucleus is slightly enlarged, pleomorphic. So we give it as grade 1 tumor, but with nuclear grading too. Now again, grade 2 tumor is 5% to 60% of the non-squamous and non-glandular patterns. So what do we see? We see more than between 5 to 50% of the tumor comprising of the solid part. Just here, and you see around a few glands over here. So this is grade 2 of the endometrioid type of carcinoma. Again, in grade 2, when there is increase in pleomorphism of the nuclear grade, we give it as nuclear grade 2. And what do you see? You see few glandular pattern, you see non-squamous solid pattern, dermatostroma, and a lot of inflammation. Now, grade 3 type of tumors with more than 50% are comprising of the solid growth pattern. In this picture, what you can see nuclear grade 2 with a lot of mitosis, the nuclei is pleomorphic with vesicular nuclei, and numerous, you can see the mitotic figures in it. This is also a picture of grade 3, where more than 50% of the tumor is replaced by the non-glandular, non-squamous element, and you see a lot of necrosis. Now there's something called a secretory type of endometrioid carcinoma. This type of tumor resembles the secretory type of endometrium. It's lined by cuboidal lining epithelium with subnuclear or supranuclear vacuolations. So that's why it has been designated as secretory type of carcinoma, but endometrioid carcinoma. But what happens, comparing it with the secretory type on the right side, you see a normal secretory type of endometrium where the background, what you call the stroma is loose. But when you see this picture, so look at this picture, you see a lot of glands, obviously there's hyperplasia of the glands, but you barely see any stroma. Compared to this picture, you see stroma over here. This is normal secretory type of endometrium. Just to compare, I've kept this slide so you can compare these two. Now there's something called mucinous differentiation. In mucinous differentiation, what you see very similar to, you'd really get confused with secretory type of endometrium, but what you see intracytoplasmic as well as extracytoplasmic or extracellular mucin, and you can just diagnose it with a mucicarmine stain. But this is also endometrioid type of mucinous differentiation that we cannot see. Now, there's something called Villoglandular type of endometrioid carcinoma. What do you see? You see a lot of villi-like structures. These are thin papillary foldings with thin fibrovascular core. And what you observe it, the lumen is plain. I mean, there is no scalloping of the lumen. So the differential diagnosis that we get because of the morphology is the serous type of carcinoma. They do look similar to the Villoglandular type, but because of the lumen, we really can comment on if it is serous type or Villoglandular type. Serous will have more broad papillae compared to this thin papillary Villoglandular type. There's something called squamous differentiation in endometrioid type of carcinoma, where you see a lot of squamous cells, typical squamous morphology with polygonal type of cell for abundant eosinophilic cytoplasm, round oval vesicular nuclei, and prominent nucleoli. There's something called chordate and hyalinite variant, which exactly is not divided in WHO, but just because of the morphology I've kept here, you can see the cells are arranged in chords, and in the background you see a lot of hyalinite stroma. There's the cells that are arranged in chords, so it is given as chordate and hyalinite variant of endometrial carcinoma. Something called Mucinous carcinoma, which has been removed from the recent WHO classification, but you see this tumor arranged in papillary fashion and filled with mucin. Something called the very important serous carcinomas. So what do you see? You see this different papillae, different papillae cut in the transverse sections. So a lot of papillae here with fibrovascular core. But when we look at the lumen is scalloped because what happens is the cells show hobnailing. There's the cells with prominent cherry macronuclei, and there's hobnailing in case of serous carcinoma. So this is a very close differential with the Villoglandular type, but these type of papillary fronds are broad and fibrotic compared to the Villoglandular, which are thin. You can see here the papillary pattern, and you can see these cells, these papillary fronds are just dispersed, and there's scalloping of the lumen of the papillae. Now, something called undifferentiated carcinomas, when we can't put them into a subtype or it's difficult to diagnose them, then we put them in undifferentiated carcinoma. Something called clear cell carcinoma, similar to the serous type, but the differential would be secretory type of endometrium. Their morphology is there's hoplaning of the nucleus with hyperchromatic nuclei and vacuolated clear cytoplasm, but are arranged in papillary fashion. Something called carcinosarcoma, where there's carcinomatous element and there's sarcomatous element. So you can see this lining epithelium as well as the sarcomatous, the spindle cells. Now, what was happening was there was significant overlap between type 1 and type 2 carcinomas, because few type 1 not necessarily showed only endometrioid morphology, and type 2 not necessarily showed only serous morphology. There was overlap between it. And what we observed, when the disease was end stage, it could be treated with surgery alone. So the patient didn't really have to undergo chemo and radiotherapy. And so what happened was, there was a molecular classification that was done by the Cancer Atlas. So what they did was, now we'll come to the updates. What they did, they divided the endometrial carcinomas into 4 major types. They divided upon the genes that were mutated. So the first one was ultra mutated or pole type of tumors. Then there was hyper mutated or MSI, that is microsatellite instability. MMR deficient, that is mismatch repair deficient type of carcinomas or tumors. Now there's something called copy number high or serous-like tumors, or P53 mutant tumors. And the last one, that is copy number low, microsatellite stable, and non-specific molecular profiling. So these are the 4 subtypes of the molecular classification that was done. So I'll be just commenting on it. So in pole ultra mutated type, we observed that there were multiple mutations. That's why it's called as ultra mutated. There were more than 100 mutations. The histological features were generally of high grade and ambiguous morphology. We really couldn't put them, mostly they were endometrioid, but we could not really put them into a fixed category that pole showed this type of morphology. So they had ambiguous morphology, and what you could see tumor giant cells and tumor infiltrating lymphocytes in it. The tests that were done to diagnose this type of tumors were a Sanger sequencing and next generation sequencing. The patient were generally of younger age and had an excellent prognosis, and the patient could be saved from chemo and radiotherapy. Just the surgery was enough, and immunotherapy was also tried in these patients. Now, MMR deficient, that is micro mismatch repair deficient or microsatellite instability feature or the molecular feature, these tumors were again high grade, had mucinous differentiation, and when I commented on the myoinvasion, it was microcystic elongated and fragmented myoinvasion type of carcinomas. So these tumors presented with this type of myoinvasion along with lymphvascular emboli. Now, when we diagnose these tumors, we diagnose it by the immunohistochemistry of MMR type and sometimes next generation sequencing. Now, these patients had a history of other tumors as well, and they were diagnosed with Lynch syndrome. The prognosis was intermediate, and the treatment that was done was these patients were sensitive to radiation, and immunotherapy was tried in these patients. Now comes a P53 type of mutant, which had less than 10 mutations. The features were again high grade with diffuse atypia, glandular and solid forms were seen, which is a bad prognosis, of course. The diagnostic test that was done for these tumors were P53 immunohistochemistry. These patients generally presented with an advanced stage of carcinoma, and the prognosis was very poor. Now, these patient did benefit from chemo and radiotherapy, but the patient had a poor prognosis. Now, the last type, which is non-specific molecular profiling, these patients had less than 10 mutations. Again, histological features were kind of low grade, and there were no tumor infiltrating lymphocytes in it. The patient presented with MMR proficient, that is, MMR is present in them, it's not mutated. Again, P53 wild type, which is a good thing, and pole mutation was absent in them. That's why we considered them as non-specific molecular profiling. But the patient had a higher BMI, and the patient had higher BMI. Now, this is just a pie chart just to give you an idea about the most number of tumors that were seen were of mismatch repair deficient or microsatellite instability. Next goes with a non-specific molecular profiling. P53 comes with 18% and pole mutations comes with 12%. Now, what was happening now, there should be an approach to molecular classification because there are four type of mutations that we have seen. So proactive molecular risk classifier for the endometrial carcinomas was given, and there was an algorithm that was made. What was the algorithm? They said that do MMR first. If the MMR is deficient in these patients, categorize them as MMR deficient endometrial carcinomas. But if the MMR is intact, next do pole mutation. If the pole is mutated, then it is pole endometrial carcinoma, or else it's pole wild type. If it is wild type, then try it with P53. If it is P53 mutant, it is P53 abnormality with endometrial carcinoma. But if P53 is also wild type, give it as a non-specific molecular profiling. So what was happening, there were 3 to 5% of carcinomas had overlap between these molecular profiles. So few pole mutated also presented with MMR deficient, few pole also presented with P53. So it's getting confusing. So what WHO did? WHO gave an algorithm. WHO said, especially in endometrioid, serous and clear cell carcinomas, that do pole first. If the pole is pathogenic, give it as pole mutated endometrial carcinomas. If the pole is non-pathogenic, go with MMR deficiency. So if the MMR is deficient, give it as MMR deficient endometrial carcinomas. If it is proficient, go with P53, and it would be P53. If P53 is mutant, give it as P53 mutant endometrial carcinoma. If not, give it as non-specific molecular profiling. In labs where this molecular testing is not done or has come inconclusive, we comment it as endometrioid endometrial carcinoma not otherwise specified. Likewise for serous endometrial carcinomas and clear cell endometrial carcinomas. Now, the NICE guidelines for all the endometrial carcinomas that was given was that, especially for the MMR deficient, because the most common, we do immunohistochemistry to evaluate the status of MMR. So what we see, If all there are four genes especially that we should be knowing about in MMR, the MMR proteins, that it is MLH1, PMS2, MSH2, and MSH6. These four always, most of the time, are lost in pairs. So MLH1 is lost with PMS2 and MSH2 goes with MSH6. So what we see when these four markers, all the markers are expressed, you can rule out Lynch syndrome. But if you see either loss of MLH1 and PMS2 or just the loss of MLH1, we have to go with MLH1 promoter hypermethylation testing. In this testing, if this MLH1 is detected, it is not Lynch syndrome, and you go forward with other type of tumor. But if this hypermethylation is not detected, counsel to the patient for Lynch syndrome. Along with that, if you see loss of MSH2 with MSH6 or isolated loss of MSH6 or isolated loss of PMS2, you have to counsel the patient for Lynch syndrome. Now, what was the benefits that were seen with MMR testing? You gave an idea, the patient idea about, you had an idea about the prognosis, and you could try immune checkpoint inhibitors with the patient, and you can also warn the patient that there are other tumors, other symptoms that he can come up with, and you can work up the patient for that. Now, all this, just to summarize it, when we come with a case of endometrial carcinoma, how do we report it? How do we report it with the latest classification? So, for example, there's a 60-year-old female who came with bleeding per vaginum for a day, also had a similar history 2 months back, and she's been postmenopausal. She's postmenopausal since 10 years. Now, USG was observed, and we observed that there was enlarged uterus, and the endometrial thickness is 20 mm. They did dilatation and curettage of the patient and was sent to us for histopath, and we reported it as endometrial carcinoma. Now, what do? They do the surgery. They do total abdominal hysterectomy with bilateral salpingo oophorectomy. Again, it was sent to us. What we do with it? We trim it and report it by the CAP protocol. How do we gross the endometrial carcinoma? When we look at the cut section of endometrial carcinoma uterus, we see either a polypoidal or diffusely involving endometrial lining. We measure and weigh the uterus. We measure the dimensions of the tumor, the location of the tumor, either it's in the fundus, the lower uterine segment. The appearance of the tumor is either it is exophytic or infiltrative, and we look at the depth of the myometrial invasion. Is it less than 50% or more than 50%? We have to adequate slice. Slicing should be done, and the sectioning of the tumor should be done. We have to give at least one section from the uninvolved endomyometrium, and also give sections from ovary, the fallopian tubes, and the parametrium. So what are the sections that we should be submitting in endometrial carcinoma uterus? We should be giving minimum of 4 sections from the tumor, 1 section from the adjacent endometrium, 2 sections from the grossly unremarkable cervix, both the ovaries, the tubes, and the parametrium. And if we have been sent with pelvic nodes or other nodes, we have to give it as well. Now, how do we report an endometrial carcinoma? First of all, this CAP protocol for endometrial carcinoma is not required for endometrial biopsy, endometrial curettage, if it has already been resected and there's no residual cancer in it, or cytologic specimens. The carcinomas in uterine cervix, uterine sarcomas, and lymphomas have different CAP protocol for them. Now, these are the following headings that we should be commenting on when we report an endometrial carcinoma. It's procedure, which procedure we have done, either total abdominal hysterectomy with bilateral salpingo oophorectomy, the type of hysterectomy, is it vaginal, it is abdominal, the specimen integrity, if it was intact, it was cut open, the site of the tumor, is it present in the fundus, in the lower uterine segment, the size of the tumor, and histologic type of the tumor. As I've already showed you, the FIGO grading, so we have to comment is it grade 1, which is less than 5% of the non-squamous, non-glandular solid pattern, grade 2, which is 6 to 50%, and grade 3 would be more than 50%. Remember, this FIGO grading is applied to the Endometrioid and the Mucinous type of carcinomas only. Commenting on the endometrial invasion that I've already said, is it MELF? Is it diffuse infiltrating? If the carcinoma also has adenomyosis with it, is the serosa of the uterus also involved? Is the lower uterine segment involved? Is the cervical stroma involved, or the other organ involved? If we have been sent with peritoneal or ascitic fluid, if is it involved, and the margins also. So if the sample that has come to us also has a vaginal cuff, is it involved, or the perimetrium along with lymphovascular invasion and the regional lymph nodes? Now, generally, we give the staging. We give P, T, and M staging. That's a pathologic stage classification, AJCC 8th edition. So it is broadly divided like PT1, which is either it is confined to the uterus, going with 2 is had invade the cervical stroma. PT3, which has involved the serosa, adnexia vagina, or perimetrium, and T4 either it has involved the bladder mucosa or the bowel mucosa. On the regional lymph nodes, if they have been sent to us, we have to comment if it's involved. If it's not, is it less than 2 mm or more than 2 mm? If we have been sent other lymph nodes from the inguinal or interperitoneal regions, we have to comment on that. Now again, the FIGO staging 2018, where again it is has a tumor confined to the uterus, or has invaded the cervical stroma, or it has gone to the pelvic lymph nodes, or it has gone to the other organs like bladder and bowel mucosa. Other findings, if you see a typical hyperplasia or endometrial intraepithelial neoplasia, we have to comment on it. Now, because of latest classification, we also do immunohistochemistry, so we have to comment on estrogen, progesterone, and HER2 receptor status, and the MMR proteins, because the most common type of molecular profiling that we have seen in endometrial carcinoma. So we have to comment on the nuclear expression of either MLH1, MSH2, PMS2, and MSH6. So in this picture, you can see, as I've told you, these two genes always go together, MLH1 and PMS2. So there is loss of nuclear expression of these tumors. So there is loss of MLH1 and PMS2. Now, in this case, you can see there is retention of the MSH2 and MSH6, though this little weakly expressed, but still we give it as retention of MSH6. So we have to comment on the microsatellite instability by the immunohistochemistry. Also go with the promoter methylation analysis that I've already talked about. In this picture, you can see we have to comment if P53 is also expressed in case of P53 mutant type of carcinomas. Thank you. Thank you for listening to it patiently. Thank you.